today's class on hypertension. So I welcome you all today's class on hypertension. Actually, it is a case-based and evidence-based lecture. So it is, I think, a second class, and hopefully we need some more classes on hypertension to to make it a complete understanding. So our case scenario was Mr. X, 48 years old, presented with neck pain and vertigo for the last 10 days. He's a smoker and dyslipidemic. His blood pressure is 175 over 105 millimeter mercury on both arms, and pulse 78 beat per minute. What the management strategy? So here the patient is 8 years old. Obviously, he's some aged, and he has got some symptoms like neck pain and vertigo. And he has also got some risk factors like smoking and dyslipidemic also, along with the hypertension. And his blood pressure is 175 over 105 millimeter mercury. In the previous lecture, this is in the first lecture, I have discussed some points that should be considered before the starting of a management of the hypertension. So as the patient, one point was in which stage the patient is now on. So we have to staging the patient according to his level of blood pressure. His blood pressure is 175 over 105 millimeter mercury on both arms, and pulse is 78 beats per minute. And what may be the management strategy? Now let's go to the next slide. So according to the JNC 7 guideline, as his blood pressure is 175 over 105 millimeter mercury, so he is in the stage 2 actually. In stage 2, systolic blood pressure is from 160 to 179. So his systolic blood pressure was 175. So systolic blood pressure in the stage 2, and diastolic blood pressure is 105 millimeter mercury. So in stage 2, diastolic blood pressure is 100 to 109, according to the JNC 6 and also the JNC 7 category. So patient is in stage 2. So in case of stage 2, we know that patient should start at least 2 antihypertensive drugs along with lifestyle modification. So lifestyle modification should be given in all stages of patients along with pre-hypertension. And with lifestyle modification, so we have to give at least 2 drugs, 2 groups of antihypertensive medication should start in this patient actually. So a JNC 8 guideline in 2014, it was published. So according to the algorithm, adult patient with hypertension should be at first, he should be intervened with lifestyle modifications. Along with his all management it includes, and his blood pressure goal should be set, and initial blood pressure lowering medication based on age, diabetes, and chronic kidney disease. As this patient has got no diabetes, no chronic kidney disease, so and age is less than 60 years, so his blood pressure goal should be systolic blood pressure less than 140 and diastolic blood pressure less than 90 millimeter mercury. So we have to lower down his blood pressure below the 140 millimeter mercury systolic and below the 90 millimeter mercury, that is diastolic blood pressure. And next, this is the actually combination drugs. As I have said that in stage 2 hypertension, patient should be given at least 2 groups of drugs. So patient should be given combination medications. So how combination usually made or combination usually chosen? Usually combination chosen. So we have to choose in different groups of drugs. That is, we have to choose one drugs from different groups. So because different groups act on different sides of the hypertension controlling center actually. So different, if we add one drug that is diuretics, so we have to give another is beta blocker or calcium channel blocker or other one. So we should not combine one ACE inhibitor or one ARB, because these groups of drugs actually acts on the same side. So we have to avoid the same mechanism of action. So we have to choose different groups of drugs that has different mechanism of actions. Like a combination may be done with diuretics and beta blockers, or diuretics or ARB, or diuretics of alpha blockers, or diuretics with ACE inhibitor or calcium channel blocker. So these types of combination can be given, can be made. So beta blocker and calcium channel blocker combination may be done. Diuretics with calcium channel blocker may be done. So, but we should not choose two groups of drugs that acts on the same side. Like alpha blocker and calcium channel blocker actually should not be given, because calcium channel blocker usually causes the peripheral vasodilation, as alpha blocker usually causes same types of mechanism of action. So this combination should not be done. So this is the principle of combining one antihypertensive group with another antihypertensive medications. So from this case scenario, what we have learned today, from this case scenario, we learned as the patient, what may be the presentations of a patient with hypertension, number one. What may be the other risk factors along with hypertension of the ischemic heart disease. So staging of hypertension, so in which stage a patient with hypertension is now on, so he should be treated as such. As the patient has got stage 2 hypertension, so he should be treated with at least two groups of antihypertensive medications. And how combination of the antihypertensive medication is usually done, in which principle usually we combine one group of antihypertensive with other group of antihypertensives. So this is the way by which combination of the antihypertensive agents is usually done. So we have learned from this case scenario today. So case 3, a 30-year-old gentleman present with headache and neck pain. His blood pressure is 160 over 100 millimeter mercury. How this patient should be treated? So here is also this patient has got some symptoms or presentation symptoms like headache and neck pain, and his blood pressure is 160 over 100 millimeter mercury. So at first we have to see in which stage of hypertension is the patient is now on, and before treatment, starting treatment, we have to have considered these 10 points we should consider. So according to the classification of the European Society of Cardiology, this is the classification of European Society of Cardiology. So this is the classification of European Society of Cardiology classification. So in European Society of Cardiology classification is a bit different. In American College of Cardiology or JNC 6 or 7, usually staging is the term of staging is used usually, but in case of European Society of Cardiology, usually used grade. the grade 1, grade 2, and grade 3 hypertension, and there is systolic hypertension. There may be high normal, but in case of agency 6 and 7, there is a pre-hypertension group of patients. So according to the European Society of Cardiology, patient is grade 2 hypertension, and this patient also should be treated with at least 2 antihypertensive medications. So along with lifestyle modification, this patient should be given antihypertensive treatment as early as possible to control the blood pressure. So what may be the first line antihypertensive drugs? Usually we should choose according to the evidence-based medicine. So evidence medicine says that the first line medications are ACE inhibitor or ARB. It is one group. Another group is calcium channel blockers, and another group is diuretic. So we have to choose. If we choose one antihypertensive drugs, then we should choose either ACE inhibitor ARB, or we should choose calcium channel blocker, or we should choose diuretics. So it depends on there may be some compelling indications, there may be some contraindications. That is actually there are 10 points that we should consider before starting of the treatment of antihypertension. So if a patient suffering from diabetes or proteinuria, or the patient has chronic kidney disease, so this patient with hypertension should be treated with ACE inhibitor or ARB at first. Usually ACE inhibitor. If patient is not tolerant to ACE inhibitor or intolerant to ACEI, so this patient should be switched over to ARB. Actually, this is the way a patient should be, antihypertension should be chosen to a patient with hypertension. So if a patient needs 2 group antihypertensive drugs, so in that cases, we should choose either one from ACE inhibitor or ARB, and another from calcium channel blocker or diuretics. This is the 2 antihypertensive drugs we should choose. And if a patient needs 3 antihypertensive medication, in that cases, we should choose one from ACE inhibitor or ARB, one from calcium channel blocker, and one from the diuretics. So this is the way we should choose antihypertensive medications. So, and what is resistance hypertension? Resistance hypertension is called when there is at least 3 antihypertensive medications, and if it includes one diuretics, and this drug is given in optimum dose, and patient is compliant enough, that is, patient is getting antihypertensives regularly, taking regularly. So, and the blood pressure is not, in that case, is controlled enough, or the patient is not responding well. So it is called resistance hypertension. So something about the beta blocker. The beta blocker is not in the first line antihypertensive medications, but if there is compelling indications, like if a patient has got ischemic heart disease, in that cases, patient should be given beta blockers in the first as a first antihypertensive medications. Or if patient has got heart failure or post-MI angina, or a patient has got atrial fibrillation, or young woman with or without planning pregnancy, so she or he should get beta blockers as a first line antihypertensive medication. So this is the way actually we choose a drug, an antihypertensive medication, or one group of antihypertensive medications in a patient. So this is the way actually we should choose the antihypertensive medications. This is the another case, case 4. So how will manage a case of 45 years old gender presented with headache and visual disturbance and papilledema with blood pressure 200 over 105, 15-meter marker, admitted in CCU ICU department. So here we see that patient has got severe symptoms like headache and visual disturbance. That is, patient has got some target organ damage. So in the first lecture, I have discussed about the target organ damage of the hypertension. So I want to repeat it because it is an important thing to memorize also. Target organ damage of the hypertension are brain, retina or eye, heart, and kidney and peripheral vessels actually, or all vessels. These are the target organ. So if patient has got visual disturbance along with papilledema, so this patient has got definitely target organ problem, target organ damage. Along with patient has got 200 over 115 millimeter mercury, that is patient has got stage 3 or grade 3 hypertensions. So the grade 3 hypertensions with target organ damage, this group of hypertension is called hypertensive emergency. So this patient should be treated with hospital admission, and this patient should be admitted in the CCU or ICU, and his or her blood pressure should be lowered down as early as possible, because if we fail to lower down the blood pressure in the appropriate amount, he or she may have other target organ damage. So what is hypertensive emergency? Hypertensive emergency, a patient is in severe hypertension or a grade 3 or stage 3 hypertension, and if patient has associated the acute target organ damage, hypertension mediated organ damage, so which is often life-threatening and requires immediate but careful intervention to lower BP, usually with intravenous therapy. So what are the points of hypertensive emergency? Patient is in stage 3 or severe hypertension along with target organ damage. Patient may have CVD, patient may have heart failure or a heart attack, or patient may have retinopathy, or patient papilledema, or patient may have proteinuria. So there may be one target organ damage, and patient blood pressure should be lowered down as early as possible, along with usually by giving intravenous antihypertensive drugs. And another terminology, besides hypertensive emergency, there is also hypertensive emergency. In case of hypertensive urgency, we may get a patient with stage 3 hypertension, but this patient usually has got no target organ damage. So as this patient has got no target organ damage, so this group of patient may be treated in the as outside outdoor settings or clinic settings. This patient may be treated, or in the patient may be treated with in home without any admission to the hospital. And this group of patients should be treated with oral medications, oral antihypertensive medications usually. So the difference between the hypertensive emergency and hypertensive emergency are both of the patients may have stage 3 hypertension, that is hypertension, severe hypertension. But in case of hypertensive emergency, there is a target organ damage. But in case of hypertensive emergency, there is no target organ damage. Number one. Number two, in case of hypertensive emergency, the patient should not need hospital admission. He or she may be treated in the home or in the as an outpatient outdoor patient, but in case of hypertensive emergency, the patient should be admitted in the hospital, especially in the CCU ICU setting. And regarding medications, in case of hypertensive urgency, the patient may be treated with oral medications, but in case of hypertensive emergency, the patient should be treated with intravenous medications to lower down the blood pressure immediately to prevent the further target organ damage or to prevent the damage of the other organs. So this is the flow chart when a patient comes with hypertensive crisis or hypertensive emergency. Systolic blood pressure is more than 180 millimeter mercury, or diastolic blood pressure is more than 120 millimeter mercury. And patient if has got target organ damage, it may be new, or it may be progressive target organ damage, or it may be worsening target organ damage. That is, patient has got target organ damage previously, and now the condition is worsening day by day, or the condition may be progressive in nature. So if the patient has got hypertensive target organ damage, in that case, the patient should be labeled as hypertensive emergency. he or she should be admitted in the ICU, these class 1 indications. And there may be some associated condition like aortic dissection or severe preeclampsia or eclampsia, or patient may have pheochromocytoma. If this is present, so reduce systolic blood pressure to 140 millimeter mercury during first hour and to less than 120 millimeter mercury in case of aortic dissection. If the conditions are not associated with the hypertension emergency, that is, the aortic dissection not present, then maybe no, there is no severe eclampsia, preeclampsia, or there is no pheochromocytoma, crisis. There is only hypertensive emergency. In that case, reduce blood pressure by maximum 25 over the first hour, then to 160 over 100 to 110 millimeter mercury over next 2 to 6 hours, then to normal over next 24 to 48 hours. That is the important point is here. If the patient has got hypertension emergency along with some critical conditions like aortic dissection or eclampsia or preeclampsia, or if patient has got pheochromocytoma crisis, in that cases, patient blood pressure lowered down should be immediately, as much as possible should be done. But in case of without any aortic dissection or eclampsia or pheochromocytoma crisis, so we may get we may lower down the blood pressure a little bit slowly. If there is no target organ damage, so we can label as hypertension emergency, urgency, and this patient should be treated as an outpatient department, or this patient may be treated also in the home, and follow-up may be done. And as a hypertension emergency or urgency, to diagnose a patient and to see the target organ damage, these are the actually workup investigations that should be done in a patient with hypertension emergency. So fundoscopy examination should be done in all patients to see if there is a retinopathy or not. Tubular ECG should be done to see the target organ damage like hypertrophy of the left ventricle. Hemoglobin, platelet count, and fibrinogen count should be done. The patient should done creatinine, EGFR, electrolytes, LDS, haptoglobin, also the spot urine to see the albumin-creatinine ratio. And urine albumin-creatinine ratio, urine microscopy for red cell, leukocyte cast should be done. Pregnancy test in women of childbearing age when suspecting the actually eclampsia, preeclampsia. Specific test in indication, troponin, CMMC is suspected cardiac involvement, acute chest pain or acute heart failure, and NT-proBNP level. Chest X-ray, there may be fluid overload. Echocardiography, we can see the aortic dissection, feature of heart failure or ischemia. In CT angiography of the thorax abdomen is suspected acute aortic disease. There may be aortic dissection. And CT or MRI of the brain may be needed to see that there is a nervous system involvement as a target organ damage. Renal ultrasound may be done to see the any renal impairment, or there may be suspect renal artery stenosis. That may be a secondary cause of the hypertension. Urine drug screen like suspected methamphetamine or cocaine use. In case of drug abuse, we may do some urine drug screening. So in the previous case scenario, what actually we have learned from the last case scenario, it is about hypertensive emergency and hypertensive urgency. If a patient present with HS3 or severe hypertension along with target organ damage, so this patient should be treated in the ICU or CISU environment, and this patient should be treated with IV intravenous drugs. Actually, this is the main message that we have to actually memorize, or we have to bear in mind. We have to keep this in our mind. These are the another case 5, a 40 years old gentleman present with ischemic heart disease with blood pressure 150 over 100 millimeter mercury. His ejection fraction is 40%. How this gentleman should be treated? So what is new here? So this patient has got ischemic heart disease, that is a hypertension with ischemic heart disease. In the last few cases, last 4 cases actually, we have seen a patient with hypertension and then may have target organ damage. But it is that patient with ischemic heart disease, along with patient has got IGF is 40%. So here she has got features of heart failure. Features of heart failure ejection fraction is the 40%. That is heart failure with reduced ejection fraction is 40% for ejection fraction. So how this patient should be treated? So here we see that what are the evidence here we found, or what we find as what are the evidences say here, that is in adults with stable ischemic heart disease and hypertension, a blood pressure target less than 130 over 80 millimeter mercury is recommended. So this in this case, patient blood pressure target or goal should be less than 130 over 80 millimeter mercury. This is the class of recommendation or class 1, and this another class 1 recommendation is adults with stable ischemic heart disease and hypertension should be treated with medication like beta blockers, ACE inhibitors, ARB for compelling indications. Previous stable angina's first-line therapy with the addition of other drugs like calcium channel blocker, thiazide diuretics, and aminocorticoid receptor antagonists as needed to further control the hypertension. So if a patient present with hypertension with ischemic heart disease with low ejection fraction, this patient should be treated with first-line antihypertensive drugs like beta blockers or ACE inhibitor. ARB should be given to improve the ejection fraction or to prevent the remodeling of the heart actually. And along with this first-line therapy, if needed, we may add other antihypertensive medications like calcium channel blocker, thiazide diuretics, or mineralocorticoid receptor antagonists, as there is a ejection fraction is low, that is heart failure with reduced ejection fraction. This is the another recommendation. And in adults with stable ischemic heart disease, the angina and persistent control hypertension, the addition of dihydropyridine calcium blocker to beta blocker is recommended. That is, if a patient hypertension is not controlled enough, that is a hypertension with ischemic heart disease, the first line drug is beta blocker. If beta blocker doesn't control blood pressure enough, in that cases, we may need the second agent. The second agent should be calcium channel blocker. So the recommendation is here, calcium channel blocker should be added to beta blocker. And adults who have had MI or acute coronary syndrome, it is reasonable to continue beta blockers beyond 3 years as long-term therapy for hypertension. If a patient has got already MI, that is ischemic heart disease or acute coronary syndrome, in that cases, to prevent the sudden cardiac death or to prevent any malignant arrhythmia, this patient actually should be treated with beta blocker. So beta blocker is then in that cases is a first line antihypertensive medications. And another level class of recommendation, that is beta blocker or under calcium channel blocker might be considered to control hypertension patient with coronary disease without heart failure who had an MI more than 33 years ago and have angina. So a combination may be needed. So in that cases, along with beta blocker, calcium channel blocker may be needed. Well, this is the flow chart. Hypertension with stable ischemic heart disease. In that cases, we have to reduce blood pressure to less than 130 over 80 millimeter mercury with beta blockers, ACE inhibitor, or ARB. These are the first line anti drugs in case of a hypertension with ischemic heart disease. If blood pressure is not controlled enough with this first line antihypertensive drugs, that is beta blocker and either ACE inhibitor or ARB, and patient still has angina pectoris. So in that cases, we have to add dihydropyridine calcium channel blockers if it is the class 1 indication, and patient has BP not goal, BP goal is not yet met, that is BP goal, BP is not controlled enough, but patient has got no angina. In that case, dihydropyridine or thiazide diuretics or MRA, mineralocorticoid receptor antagonist, may be added as a second-line therapy, and this is the class 1 indications. And heart failure with reduced ejection fraction. In that cases, what type of drug usually we should give in case heart failure with reduced ejection fraction, the combination for treatment with reduced ejection fraction, adults with heart failure with reduced fraction and hypertension should be prescribed with to attain a BP of less than 130. That is target blood pressure is less than 130/80 mmHg. And non-hydropyridine CCB calcium blockers are recommended in the treatment of hypertension in adults with heart failure with reduced ejection fraction. That is, if a patient suffering from heart failure with ischemic heart disease with reduced ejection fraction, actually, in that cases, non-dihydropyridine calcium channel blockers, that is amlopidine and nifedipine, this group of drugs should not be given in a patient with hypertension with ischemic heart disease or with heart failure with reduced ejection fraction. These groups of drugs should be avoided. And this is actually the evidence that is calcium antagonist, dihydropyridines. This should not be given. This contains heart failure with reduced ejection fraction, or if a patient has got heart failure with class 3 or 4 NOI, say class 3 angina, heart failure or symptoms. So this is the evidence. So in the last case scenario, what we have learned? In the last case scenario, we have learned that if a patient has got hypertension with ischemic heart disease, so this patient should be treated with beta blocker, beta blocker as a first line antihypertensive drugs, that is beta blocker. If a patient has got hypertension along with heart failure, along with ischemic heart disease, in that case, first line drug should be beta blocker along with beta calcium channel blocker, or along with beta blockers, ACE inhibitor ARB should be given. If blood pressure is not controlled enough with this first line antihypertensive drugs in a patient with hypertension and ischemic heart disease with heart failure, in that cases, what the next line of antihypertensive we should add it? If there is another antihypertensive in that cases, we may add calcium channel blockers, we may add thiazide diabetics, or we may add mineralocorticoid receptor antagonists. So this is the way actually we should choose an antihypertensive in a patient with hypertension, with ischemic heart disease, with heart failure, with reduced ejection fraction. So this is the way how we should choose an antihypertensive in a specific situation or in a special situation. So I think we have already discussed 5 cases today. So in the next cases, we have more, next class, we have more cases to discuss, and discussion should usually will be based on case-based and evidence-based. So we can actually stop here today.